So hello doctors. Today we are going to discuss about the appendicitis, a very important topic again for the clinical perspective and for the NEET PG point of view. Today we are going to discuss the appendicitis like the previous video from the latest edition of Levin Bailey textbook of surgery 28th edition, and we are going to cover the clinical part from the SDAS latest edition. So these are the reference for this video. For theoretical part, the reference is Levin Bailey, and for the clinical part, the reference is SDAS latest edition. So let's start without any delay. After watching this video, you will get to know everything about the appendicitis, like what is the position of appendix, its etiology of appendicitis, the symptoms, signs, and the differential diagnosis, investigation and the diagnostic criteria, and management part. And then we are going to discuss about the surgical management and the post-operative complication. So after this video you will get to know all about these things. So let's start with the position of appendix. So as you know, the colon continues into the cecum and which divides and into the appendix. Here this is the colon and this is the ascending colon, sorry, this is the cecum and this is the appendix. And here you can see this structure which is known as tinea. These are 3 in number and these ends into the appendix. So what is the importance of knowing the tinea? So during the surgery, when the surgeon is unable to found the appendix, he will see the tinea on colon or cecum because it is easy to identify tinea. Then he follows the tinea and finally he ends up finding the appendix. So this is the importance of tinea. It helps in identifying the appendix during the surgery. So in different person there is different anatomy of appendix on the basis of position. In many of the patient, the appendix is retrocecal, means the appendix will be found behind the cecum. So this is behind the cecum and this is known as retrocecal appendix, which is the most common position of the appendix. And in some patient the appendix is found in the pelvic region, which is the second most common position of the appendix, and the other ones are post-ileal behind the ileum, pre-ileal in front of ileum, and the subcecal below the cecum. So these are the position of appendix, and you can be asked in exam what is the most common. So most common is retrocecal and the second most common is pelvic, and if you are asked about the least common, then the answer will be post-ileal. So these are the 3 questions based on the position of appendix. After this we are going to discuss the etiology of appendicitis. So let's discuss the etiology behind the appendicitis. Let us assume this is the appendix, and if there is luminal obstruction or narrowing of lumen, means something obstructing the lumen directly or indirectly, something like this, which can press on appendix, will lead to narrowing of lumen of appendix. So in the lumen there can be fecolith. What is the fecolith? Fecolith include fecal matter and calcium phosphate, epithelial debris, and the bacteria. These 4 things constitute the fecolith. So the fecolith is the most common cause of appendicitis, and there can be stricture in the lumen. The stricture, it will be common in previous appendicitis. So if there is first attack of appendicitis, it will lead to the inflammation and there can be formation of stricture, which can again cause the appendicitis. So there is repeated attack of appendicitis, and there can be tumor. In elderly patient there is risk of CA colon If there is CA colon, there will be enlargement of lymph node due to the local spread, or the tumor can directly put pressure on this appendix and leads to the lumen obstruction and then to the appendicitis. So this can be one cause. Or in children's, there can be intestinal parasites like Enterobius vermicularis, or also known as pinworm, which can obstruct the lumen of appendix. And there can be lymphoid hyperplasia. As I already discussed, there are lymph nodes which can be enlarged due to the any reason and cause the narrowing of lumen by putting pressure on the wall of appendix. So these are the things which cause the appendicitis, and this appendicitis sometimes lead to the perforation of appendix. And what is the pathophysiology about the perforation of appendix? Here, if there is narrowing of lumen of the appendix, there will be mucus discharge and bacterial growth. Here the one point to remember is the bacteria are aerobic and anaerobic. So this is the mixed infection. Appendicitis is the mixed infection, and due to these two factors, mucus discharge and bacterial growth, there is edema of wall of appendix, which leads to the compression on the veins, and which further lead to the compression of arteries, and then lead to the ischemia, which leads to the necrosis, and there is perforation of appendix. And due to this ischemia, there is weakness of wall of appendix, and the bacteria invades into the peritoneum, which lead to the peritonitis. So this is the pathophysiology of perforation of appendix and the peritonitis in case of appendicitis. So this is the etiology and the pathophysiology for the appendicitis. So after all these, what is the symptom the patient present with in the OPD? So there will be para-umbilical colic. Peri-umbilical means around the umbilicus there is colicky pain, and the main difference between the intestinal colic and the appendicitis colic, that this colic of appendicitis is less intense than colic of obstruction, and it's mainly around the umbilicus. Then after the inflammation of parietal peritoneum, the pain migrates to the right iliac fossa, and now the pain is sharp and localized. So in appendicitis, there will be migration of pain. So what is the meaning of migration of pain? That the pain will start on the umbilicus, and after that it migrates toward the right iliac fossa. But when the pain present in right iliac fossa, there will be no pain at umbilicus. The patient only complain of pain in right iliac fossa. So this is known as the migration of pain. So there are three terms: radiation, migration, and referred pain. These three are different, and here we discussed only about the migration of pain, and I will discuss about these three differences in the last of this video. So first of all, there is a pain which start at umbilicus and radiate toward the right iliac fossa. Migrate toward the right iliac fossa. And there is a complaint of anorexia, means there is loss of appetite, and there is nausea or vomiting and the fever. So this is the triad: pain, vomiting, fever. This triad is known as Murphy's triad. The name of triad is Murphy's triad. So by this triad you can remember the symptoms of appendicitis. So let's now discuss about the signs. So there will be pyrexia or fever around 37.2 to 37.7 degrees Celsius. There will be localized tenderness in the right iliac fossa, means there will be pain on palpation in the right iliac fossa at the McBurney's point. So what is the McBurney point? We are going to discuss this in this picture. And there can be muscle guarding. So muscle guarding, in guarding, the patient voluntary contract the abdominal muscle to protect him from the pain caused by the palpation. So there will be muscle guarding. And there can be sign of rebound tenderness. In rebound tenderness, we will put our hand at the right iliac fossa and we then suddenly remove our hand from the abdomen. So on removing the hand, the patient complain of pain. So this sign is known as rebound tenderness. For this sign, you can see our last video on abdominal palpation part 2 to know more about these signs. I have explained on the patient on that video in detail. So rebound tenderness. So now we are going to discuss what is the McBurney's point. So here is the umbilicus and here is the bony landmark anterior superior iliac spine. So we measure the distance 2/3 from the umbilicus and 1/3 from the anterior superior iliac spine. Then there is a point here which is known as McBurney's point, and in case of appendicitis there is tenderness. So this is the McBurney's point, and we have discussed the signs of appendicitis. Now there are some other signs specifically for the appendicitis. One of them is pointing sign. Pointing. In pointing sign, the patient put his finger at the right iliac fossa to tell the exact site of pain. So he will point toward the site of pain. That's why it's known as pointing sign. So after the pointing sign, we are going to discuss about the Rovsing sign. So in Rovsing sign, on palpation of the left iliac fossa, there will be pain in the right iliac fossa. Here we are going to palpate here in right iliac fossa, and there will be pain in the right iliac fossa because the appendix is already inflamed. Due to the pressing here, the bowel will shift on the right side, like ileum will shift on the right side, and it hits on the inflamed appendix and cause pain. So on pressing in the left iliac fossa, there will be pain on the right iliac fossa due to the shifting of ileal bowel loops, which is known as Rovsing sign. And now we are going to discuss about the psoas sign and the obturator sign. So the psoas sign tells you about the retrocecal appendicitis, and the obturator sign tells you about the pelvic appendicitis. So in psoas sign, there is pain on extension of hip. The patient complain of pain in the right iliac fossa on extension of hip. Here in this picture you can see. And in obturator sign, the patient will complain of pain in the right iliac fossa on internal rotation of hip. There is internal rotation of hip. The patient will complain of pain in right iliac fossa. So these are the 4 signs of appendicitis: rebound tenderness, Rovsing sign, psoas sign, and obturator sign. So after discussing the signs of appendicitis, we are going to discuss about the differential diagnosis of appendicitis. So in differential diagnosis, there is division according to the age group, like in children, elder, and the adult, male and female. So in children, there can be acute gastroenteritis. So there will be history of diarrhea. And mesenteric and adenitis means there is mesenteric lymph node enlargement, which is characterized by the diffuse abdominal pain. So this is the clinical point here, and this is the clinical point here. In Meckel's diverticula, this is the congenital condition, and here can be intussusception. In intussusception, there is passage of red currant jelly stools and a sausage shaped lump in abdomen. So these are the clinical point for this. And one is HSP. HSP means Hinosh Scholin purpura, in which there is rashes, pain abdomen. So if there is rashes, pain abdomen, and there is involvement of renal system. So these are the points for HSP. And there can be lobar pneumonia. So if there is pathology in lungs, this can cause pain abdomen. So these are the 6 differential diagnoses in case of a children who present with pain in right iliac fossa. So after discussing these points, we are now going to discuss about the differential diagnosis in elder. So in elder, there can be one cause like diverticulitis. What is the diverticulitis? In old patient, there is constipation, and due to the constipation, there will be increase in intraluminal pressure of descending colon, and the mucosa protrudes out, which is known as diverticula. If there is infection and inflammation in these diverticula, this is known as diverticulitis. So the one differential diagnosis is diverticulitis, and the other is intestinal obstruction. There can be CA colon or mesenteric infarction, and there can be aortic aneurysm. There is in elder patient, these are the 5 differential diagnoses for the pain in right iliac fossa. So you have to rule out these in case of elder patient. And in adult, there are many differential diagnoses. Like in male, there can be terminal ileitis. So this is the cecum, this is the ileum, and this is the appendix. There can be infection or inflammation of ileum, which is known as terminal ileitis, and there can be history of diarrhea. So after the terminal ileitis, the second differential diagnosis is ureteric colic. So there will be history of pain around right iliac fossa or flank region, which is radiating to back. So there will be radiation of pain to the same side on backs in case of ureteric colic. In case of pyelonephritis, there will be history of pain in flank region with chills and rigors. So this will be the point on history in favor of pyelonephritis. And there can be perforated peptic ulcer disease, in which there is a history of pain starting in epigastrium, which will then shift to right iliac fossa, and you can see air under diaphragm on chest x-ray. So this is the points in favor of perforated peptic ulcer disease. There will be pain in the epigastrium region, which will shift to the right iliac fossa, and there is history of pain, and there will be air under diaphragm on chest x-ray. There can be testicular torsion. So in case of appendicitis, you always ask about the any scrotal swelling with pain. So this is the also the differential diagnosis of appendicitis. And in case of appendicitis, you have to rule out pancreatitis, in which there is pain in epigastrium radiating to back. So pancreatitis can be 1DD. And if there is history of trauma to abdomen, there can be rectal sheath hematoma, and there can be intestinal obstruction because the pain of intestinal obstruction is mainly around the umbilicus, and there is a history of constipation or obstipation. In obstipation, the patient is unable to pass the flatus. So this is the history in case of intestinal obstruction, and there can be history of bleeding PR or mass in right iliac fossa. So this will points toward the CA cecum. So these are all the DDs of appendicitis in case of a adult male and you have to differentiate them on the basis of history. I have already discussed about the clinical points which point toward the particular diagnosis. So after the male, we are going to discuss about the DDs in adult female. So there can be Mittel-Schmerz syndrome, in which on day 14 ovulation occur, and due to the rupture of ovarian follicle there is pain. So you have to ask about the menstrual history. It can be PID, pelvic inflammatory disease. So in this there will be history of white discharge per vaginum and pain radiating to lower back, and there can be history of pyelonephritis, and it can be a ectopic pregnancy. So always ask about the LMP of patient to rule out amenorrhea. So a female patient can be present with right iliac fossa pain, can have a ectopic pregnancy. So to rule out the pregnancy, we ask the patient about the LMP, and we are going to order a UPT test, urine pregnancy test. There can be torsion or ruptured ovarian cyst or endometriosis. So you have to rule out these differential diagnoses in case of a female present with right iliac fossa pain. So these are the differential diagnoses in female, male and children. We have covered all. Now we are going to diagnose the case. So for diagnosis of the case, there is a score known as Alvarado score, and we can do investigations to confirm the diagnosis. So in Alvarado score, we can remember it via mnemonic mentrals. So what is the meaning of M? There is migratory pain, anorexia, nausea, vomiting. All these three symptoms are given 1 point, and there can be tenderness in right iliac fossa, rebound tenderness or elevated temperature. Out of these three, we are going to give 2 point to tenderness in right iliac fossa. These are the signs, and then we are going to order some laboratory investigation like leukocytosis, and there will be shift to left in DLC. So we are going to give 2 number to leukocytosis. So you can remember by LT2. So for leukocytosis and tenderness, there will be given 2 points. So if the score is greater than 7, then this is the strongly predictive of appendicitis, and if the score is 5 to 6, then it is equivocal score. You have to do USG or CCT abdomen to confirm the diagnosis of appendicitis. So in investigation, we are going to order a CBC, urine analysis, and like selective investigation on the basis of differential diagnosis, pregnancy test, urea and electrolytes in case of RFT derangement if the cause is renal, CRP for the systemic inflammation, abdominal X-ray to rule out the intestinal obstruction or perforation, USG whole abdomen and pelvis to rule out the female causes and other causes, or CCT. So these are the investigation we are going to do in case of appendicitis. Then we come to the treatment part. For treatment, there is 2 type of management. Non-operative, we are going to manage this case conservatively, and the operative management, where we are going to perform the surgery either via laparoscopic appendicectomy or open. So in which case you are going to do the non-operative management in uncomplicated appendicitis. So uncomplicated appendicitis means there will be absence of appendicolith, there will be no perforation or abscess. So this is the medical management in case of uncomplicated appendicitis. We keep the patient NBM, nil by mouth or nil per oral, and we are going to give him IV antibiotics. And in case of appendicitis, the drug of choice is third generation cephalosporins like ceftriaxone and metronidazole to cover the anaerobic bacteria. So this is the medical management in case of uncomplicated appendicitis. And in case of appendicular mass, what happened if the patient of appendicitis present after 3 to 4 days or after 48 hours in hospital, there will be formation of appendicular mass in right iliac fossa due to the property of omentum. Due to the inflammation in the right iliac fossa, the omentum and the bowel goes there, and the mesentery, omentum, mesentery and bowel goes there and form a lump to limit the spread of this inflammation, which leads to formation of appendicular mass there. So for appendicular mass, we are not going to perform surgery in the same sitting. We firstly going to manage this case of appendicular mass via medical management. First of all, we are going to medical management, then we, after 3 to 4 week of interval, we are going to do interval appendicectomy. So we are going to perform surgery after 3 to 4 weeks, and we will wait for the resolution of this appendicular mass. So the medical management which we are going to given there for management of this mass is known as Ochsner-Sharon regimen. So there will be question, what are the things you are going to do in Ochsner-Sharon regimen? So Ochsner-Sharon regimen, in this regimen we monitor the patient vitals daily, and we will monitor the extent or size of mass on daily basis. We can perform CCT abdomen. We will give the patient IV antibiotics and IV fluid. We keep the patient NBM, and we will monitor the temperature and pulse rate 4 hourly, and we are going to do the input output charting in case of urine output. So these are the things we are going to do in Ochsner-Sharon regimen. If the mass resolve within 24 hours or there is resolution starts in 24 hours, we are going to continue the medical management. And when we are going to stop this conservative management, when there are following things, any one of them. If the pulse rate increases and there is increase or spreading abdominal pain to patient, if there is increase in size of mass after the medical management. So these are the 3 things. If any one of them present, we are going to stop the conservative management. Like if there is increase in pulse rate or patient complain of pain despite of medical management, there is increase in size of mass, then we are going to do the surgery in case of this appendicular lump. So in case of operative management, there are 2 options: open appendicectomy or laparoscopic appendicectomy. So you have to ask about the incisions given in open appendicectomy. So there are 3 type of incision. First is gridiron, then Rutherford, and then lens. Now we are going to discuss them with the help of images. So in gridiron incision, we are going to give a perpendicular incision to the line joining the umbilicus and the anterior superior iliac spine. We measure the distance 2/3 from the umbilicus and 1/3 from the anterior superior iliac spine. We join a line and we are going to put a perpendicular incision at McBurney's point. So this is known as gridiron incision. And in Rutherford Morrison incision, this is the form of gridiron incision, but here we are going to cut two muscles, internal oblique and transverse muscles. So if we are going to give a muscle cutting incision, then the incision is known as Rutherford. And if we have to extend this incision, we will extend it above here and laterally like this. So this is the Rutherford Morrison incision, in which we are going to cut the two major muscles like internal oblique and transverse muscles. And in lens incision, this is the horizontal incision. This is the horizontal incision, and we are going to give this incision 2 centimeter below the umbilicus, like here 2 centimeter below the umbilicus, and it is centered on mid clavicular and mid inguinal line. So this is the mid clavicular line and this is the mid inguinal line. Here is the anterior superior iliac spine and this is the pubic symphysis. We are going to draw a line between these two and we are going to draw mid clavicular line here. So here is the point and we are going to put a horizontal incision 2 centimeter below the umbilicus. So this is the lens incision, which is horizontal, and in gridiron and in lens incision there is no muscle cutting. The muscle cutting only present in case of Rutherford Morrison incision. So this is the all about the surgeries we are going to perform. We are now going to discuss about the post-operative complication. So in the post-operative complication, the first is wound infection. There will be pus discharge from the incision site on day 4 or day 5. It is the most common complication of appendicectomy. So what is the management of this? We have to clean the wound on daily basis, daily dressing, and we have to drain the pus from the wound, and we are going to shift the patient on higher antibiotics. So this is the management of wound infection. And there can be intra-abdominal abscess. On day 5 or day 7, the patient will complain of fever, anorexia and prolonged ileus. The flatus not passed. Normally, in paralytic ileus, the patient will pass flatus on post-operative 2nd or 3rd day. And if the patient complain of not passing flatus beyond this period, like greater than 3 days, the patient can be lead to the formation of abdominal abscess, and for this we are going to do a USG or CT abdomen, or if there is any abscess we are going to drain it via the percutaneous drainage or via surgical exploration. We are going to do the laparotomy in case of abdominal abscess. So after these two, there is the third complication, which is known as the fecal fistula. So in fecal fistula there is leakage of fecal matter from suture line. So the fecal fistula can be formed due to the prick of needle into the cecum. So if the surgeon during the repair of peritoneum takes a prick from the cecum, so there will be a fecal fistula between the cecum and the skin, and there will be leakage of fecal matter from the suture site. So it can be due to the mistake of surgeon, or there can be slippage of ligature from appendicular stump. So before cutting the appendix, we tie a suture here and here, and we cut the appendix between these two suture. If this suture slips away, there will be leakage of fecal matter from the base of appendix, and it can be a cause of fecal fistula. So there can be two causes of fecal fistula. Firstly, the surgeon during the repair of peritoneum mistakenly prick the cecum, or there can be a slippage of ligature from the base of appendix, which leads to the formation of fecal fistula. And there can be intestinal obstruction due to the adhesions formed during the gut handling in case of appendicitis. So if we handle the gut during any abdominal procedure, there can be risk of adhesion between the intestinal lobes. which leads to the obstruction. So this is known as adhesive intestinal obstruction, which is the most common late complication of the appendicectomy, and the patient will come with pain in right iliac fossa or with obstipation. So in this case we are going to do a diagnostic laparoscopy, and with the help of laparoscope we will do the adhesiolysis. We are going to break these adhesions with the help of laparoscopy. So this is the one complication, most common late complication of appendicectomy. And there can be a respiratory complication, atelectasis, which happens around post of day 1 or 2. So in this we are going to give him chest physiotherapy and proper analgesia. And there can be risk of portal pyemia. The infection from the abdomen can travel via portal vein into the liver, and this is known as portal pyemia. In this case we are going to give him a systemic antibiotics, and we are going to drain the any pus or any local fluid accumulated in the abdomen via percutaneous drainage to inhibit this sepsis. And there can be ileus if there is delay in passing flatus post-operatively. So ileus persisting more than 4 to 5 days with fever. So the ileus will prolong due to the infection or intra-abdominal abscess. So we have to do a CT abdomen here to rule out the intra-abdominal sepsis. And as you all know, after the surgery the patient lying down for 2 to 3 days, so there will be risk of DVT. So for this we ask the patient to mobilize as early as possible to decrease the risk of deep vein thrombosis, and we can give him prophylactic anticoagulant like low molecular weight heparin. So this is the all about the topic of appendicitis. If you have any doubts you can ask us in comment section, and if you like the content please subscribe our channel and share with your mates. We are uploading all these theoretical lectures from the standard book of Love and Bailey. So for more you have to visit our channel on regular basis. Thank you so much for this session.